Okay, well, we'll maybe get started. So welcome everybody to today's ISBNPA Implementation and Scalability SIG webinar. We have two fantastic speakers today who will be talking about research designs, theories, frameworks and models in relation to dissemination and implementation research and how they actually apply to physical activity, nutrition and advancing that field. For those of you who aren't already a member of our SIG, we do encourage you to join. You can do that via the ISBNPA website. We regularly share updates and events and resources. And likewise through Twitter, if we can encourage you to follow us, it gives you another sort of access to our resources. We will be holding our second annual meeting in Hong Kong this year, and we bring together a group of international experts in implementation research. So hopefully we'll see most of you there. Just to remind those of you who haven't participated in one of these webinars before, the webinar is actually being recorded and it will be available after the session online on the ISBNPA website. So if you aren't able to stay for the full hour, please still continue to leave questions and you can log on and download the session. We do encourage questions throughout. So whenever you think of a question, please use the question and answer button to upload that immediately. And if you do have a specific speaker that you want that targeted to, please just make that noted in the question. I will collate all of these questions throughout the webinar, and then in the last sort of 10-15 minutes, we can have a debate. At the very bottom of your screen, you should see a Q&A option. That's ideally where you can leave the question. Okay, so without further ado, I'll introduce our two speakers today. So both speakers are joining us from the Prevention Research Center in the Brown School at Washington University in St. Louis. Dr. Rachel Tabak is a research assistant professor who investigates interventions to promote healthy nutrition and activity behaviors in families. And this includes translation of evidence-based obesity prevention interventions that allow for broad reach. In particular, Rachel examines how stakeholders, and this includes researchers, advocates, and policymakers, how they use research evidence and it's translated into programs and policies. Dr. Stephanie Mazzucca is a postdoctoral research associate, and her research interests include nutrition and physical activity promotion among young children, the measurement of obesogenic behaviors and environments, and the efficient translation of research into practice. In this webinar today, Dr. Tabak will present on the application of theories, models and frameworks to enhance D&I research, and she'll discuss the use of an online tool to support framework identification. In the second half of the webinar, Dr. Mazzucca will discuss the selection and use of D&I study designs in D&I research. Okay, so I'll hand over to Rachel now, who'll give you a webinar outline.
Okay, can you see that appropriately?
Yeah.
Okay, great. So what we'll talk about is a little bit of overview on D&I and kind of the background on D&I science, a little bit about the spectrum of research available in this field and how it can apply to nutrition and physical activity promotion. Then I'll talk specifically about models and frameworks, and Steph will talk about study designs. So dissemination and implementation are actually sort of American terms for this field. Different countries use terminology different. So sometimes it can be called knowledge exchange, knowledge transfer, knowledge translation, implementation science, research utilization, or scale up. There are a lot of different terms. Some of them have different meanings, some of them have distinct meanings, and some of them are used sort of more loosely. So in America, we use these terms dissemination research and implementation research as defined by our Institutes of Health, National Institutes of Health, with dissemination research focusing on the spread of ideas and implementation research focusing on putting an intervention into place. Other countries like Canada, where they use a broader term like knowledge translation, combine these two ideas into one, because in reality, there's a lot of overlap between spreading an idea and putting it into place. And so I think a lot of what we think about when applying dissemination implementation science to our field, nutrition and physical activity, is it can seem scary, it can seem overwhelming. It's sort of this new field for a lot of people, but really it's just a language, and that a lot of what the language talks about are things that we already do in D&I science. And just another set of names or categories for how we might label our science. We focus more in D&I on sort of translation, more from a behavioral intervention to the community, or a community level intervention going larger than focusing on developing an intervention specifically, or more of a bench science kind of approach. So we do know that D&I science is important. We see a consistent gap to apply evidence to practice. In a more clinical setting, we see that 30 to 40% of patients don't get treatments that are proven to be effective. And we see that on the flip side, 20 to 25% of patients get care that's not necessarily needed, so that's not evidence-based and that could be harmful. And so this suggests that there should we implement research findings, that we could really change healthcare and really optimize care, and that this is a pretty steep challenge to address. And much of what we know is from this sort of healthcare setting, and I think in nutrition and physical activity, we're often working outside the setting where there's even less science around how to put research findings into practice. So I find this diagram of sort of what is D&I science to be really helpful in thinking through what categories of activities that we are talking about when we talk about D&I science. And so on the left-hand side, I think of sort of inputs, and on the right-hand side, I think of outcomes, and I'll fill this in to sort of what makes these two blue boxes different. But I think in D&I science, one of the things that we do is we distinguish what is the evidence-based intervention. So here it could be a, it's in this figure is a evidence-based treatment. And then we separate that. So in nutrition and physical activity, that might be something like the diabetes prevention program, which is an evidence-based intervention. And we separate that from what is in normal science, what we do is we then try to measure an outcome. So did the diabetes prevention program lead to a change in clinical health status? Did it cause weight loss? Did it cause a decrease in A1C? And we sort of think cause and effect, that the intervention will lead to the treatment effect, but a lot of things happen in between. And so what D&I distinguishes is what is that evidence-based treatment, and then what is the implementation strategy to put that evidence-based treatment into effect. And that there are really two inputs we have to think about: the evidence-based intervention, and then the strategy to put the intervention into place in a setting. So a school or a work site or a community center, a setting that's not just doing the diabetes prevention program by itself, but that something has to happen to make it so that that intervention can happen in that setting. We also think about outcomes that might come before or along with patient level outcomes. So D&I really carefully considers implementation outcomes, many of which are things that we as behavioral scientists think about and might talk about already, things like feasibility, fidelity, acceptability, but D&I explicitly puts these on a pathway. And then in between also service outcomes. So does the intervention effect happen equitably across all participants? And so it's this middle part really focusing on the implementation strategy, so a level of intervention that's not just the intervention, and then these other outcomes that might come before or come along with a patient level outcome. And the other thing to notice about this is that the entirety of this process is nested within context, and that it's the context of that intervention, where the intervention is happening, that can be really important in whether the intervention happens as it should, and whether patients have the outcome, or clients or participants have the outcome that we intend.
And so I'm Steph. We're going to switch just for this intro, just for a quick second. So to dig into what Rachel just mentioned about kind of the key tenets, the implementation strategies and the implementation outcomes, and how those look within D&I research. If you go to the next slide, Rach. on the next slide will be some work that others did. So Byron Powell and Enola Proctor and their colleagues have done a lot of work to figure out, when we say implementation strategies, what do we mean? What are the things and the types of strategies that might be necessary for successful implementation of an intervention or of an evidence-based intervention? So this reference here is a really great one. They've done a lot of work to define these implementation strategies and come up with a taxonomy of them. And they've found just over 70 implementation strategies and grouped them into these 9 different groupings that we see on this slide. So these are things that were generally that I think people in nutrition and physical activity and sedentary behavior are already thinking about. It's just kind of putting a name to, well, this is a formal strategy that we need to understand and articulate in order to replicate our D&I efforts across different studies. And then on the next slide, if we think about the implementation outcomes, to me, as someone who's still relatively new to D&I, these are always what I thought about as process outcomes, but here we're thinking about them as implementation outcomes. So a lot of times we see that those are really the same thing. And Enola Proctor has come up with kind of the gold standard outlook of implementation outcomes. And these range from anything from the acceptability of the intervention, adoption of the evidence-based intervention into practice, whether it's appropriate or feasible for that setting, whether the implementation strategies that you put into place, how those affect the setting's ability to implement the intervention with fidelity to its core components. Things like cost and sustainability also come up as kind of the most important proximal outcomes within the D&I paradigm. And if we think about this in terms of an example from something that we might feel a little bit more comfortable with, so Rachel mentioned the diabetes prevention program. So this is an intervention that has a lot of evidence behind it. And if we think about it, we just kind of look at this from a slightly different angle. We would think about maybe doing a D&I study with the DPP, looking at the effect of a couple different implementation strategies. So maybe we're implementing it into a new setting. So we need to conduct a needs assessment to understand what the needs within a particular community health center are, and come up with some sort of standardized way to promote adaptability. So we know that with different settings and every time you move to a different environment, you need to kind of tinker with the way that you implement something, but we need to do it in a standardized way that we understand the process by which things were adapted. And then things like audit and feedback come up a lot with, that's a very common implementation strategy that I have seen in the literature. And this is essentially the same thing as self-monitoring and feedback as we would think about it in a behavioral context. So this instead would be the folks who are implementing the intervention, monitoring their implementation and getting feedback from the study team. And then we would look at this in relation to how the fidelity and cost, so the fidelity to the original DPP and the cost to local community health centers and things like that, instead of having to go all the way then out to calorie intake and weight loss as we would do in efficacy and effectiveness research. And so when I think about D&I on the next slide, we can see the spectrum of research from efficacy to implementation. So we move from efficacy studies, which are highly internally valid, working under ideal conditions, could a program ever work in the best of circumstances? And then moving all the way out to how do we make programs work and how do we have successful implementation of programs over a long period of time out in the larger community. And so I think one of the most important things to think about with the difference between D&I research and efficacy and effectiveness is the tension between internal and external validity. And so I have a little cartoon. When we think about these things, in our research methods 101 classes, we think about these two being kind of opposite forces from each other. And the way that we mitigate threats to each of these are by making choices to our study designs and the models and frameworks with which we think about our studies. And when I think about efficacy and effectiveness research, we're thinking about, like I said, highly internally valid studies. And D&I is really putting a premium on external validity. So how are we making things work in terms of different groups of people, different ways that we're implementing or giving our treatment, looking at a couple different sorts of outcomes, and then thinking about all the varieties of settings that we implement our interventions. So if we just kind of think about the tension between these two forces, with D&I, we're putting a premium on external validity, and the factors of our research will reflect that.
Okay, so I'm gonna just give a little overview about theories, models, and frameworks that we can use in D&I research to help build studies that will really provide that external validity and that other kind of evidence that might be as beneficial as some of that in the evidence that is derived from a study with strong internal validity. I did just want to review the terms as we've been using them for theories, frameworks, and models. Normally, when I'm talking about this kind of topic, it's to an audience that's very diverse in terms of their knowledge about theories and frameworks and where they come from. We are all from sort of a similar background and have a little bit more similar idea of what is a theory, what is a framework, but because of the variety of backgrounds that people come to D&I science from, we have decided to sort of use the general term model because there's varying levels of theoretical background or empirical evidence for the different models that I'll present. So I'll just collectively refer to them as models. So just to give a brief idea of where this all came from, we started this with a review of models that were available for D&I science. We focused on excluding models that focused on individual behavior change. And so those would be some of the ones that we might be familiar with from learning to develop behavioral interventions. We really wanted models that focused at a higher level, practitioner or clinician level. We didn't want models that were just a national level plan, but we wanted models that applied to a bunch of different levels on the social ecological framework. We looked only at models that were in English. And as part of this review, what we identified were some categories that the models fell into that we thought would be helpful for investigators trying to pick a model to inform their study. And so what we identified the models, we gave them these categories, and we also set about to contact the authors to make sure that we had the right references and titles and things like that for their model. And so these are the categories we identified. They just sort of emerged as we were going through this list of models that we identified. We categorized models based on how flexible we felt the constructs in the model were. So a broad model gives you a lot of room, a lot of flexibility to sort of change and modify a model and apply it, whereas an operational model is a little bit more step-by-step, tells you a little bit more detail what to do, but might be difficult to apply sort of across fields or from a field that is different from the one it was developed in because it's a little bit more prescriptive. We also categorize them on how they apply to the categories of dissemination versus implementation. So whether the model was more focused on spreading an idea versus putting an evidence-based intervention into place in a setting. And finally, we categorize whether the models applied at different levels of the social ecological framework. We tried to be as inclusive as possible, but we wanted people to be able to, if they were thinking about a study in particular, find a model that had been applied at the level that they were thinking their study would operate as well. And we also did note models that looked at policy. So we found initially 109 models. We ended up excluding several. A number of those were because they focused on more the practice of dissemination and implementation as opposed to on dissemination and implementation research. And I'll come back to these 26 models that we excluded in a minute. But in the end, we ended up including 61 models in our review. And we've created a couple of different resources for folks for those. So we have in our paper just a table that lists out each model and how it's categorized. I'm just going to go quickly through these because what I want to get to is our website, which I think is possibly more useful than the tables that are in the paper. We did find a good amount of variety in terms of what models were available. We didn't find any categories on construct flexibility or dissemination to implementation. where there weren't any models. We did find that there were some categories where there were none when we cross tabulated them. So there were the sort of broad models didn't tend to be as focused on implementation, but generally there were a good dispersion of models across these different categories. We have a table in the paper that also provides this and tells you which models fall in these different crosstab categories so that you can narrow your search a little bit. If you were looking for a model, you could narrow it down to one of these boxes and maybe search that one box and the boxes close by it so that you don't have to look through all 61 models, that you can just narrow your search a little bit. So I find this table to be somewhat helpful for that. We also have an appendix table, and I'm sorry the top got a little cut off here, but I find the appendix table to actually be one of the most useful parts of the paper. This gives you the names of a bunch of different models. It still tells you whether they're dissemination or implementation focused, how flexible the constructs are, what levels of the social ecological framework it applies to, and you can kind of scroll down that list to find ones that are sort of tick off the levels you're interested in. But the other thing we added in this table was the field of where the model was originally developed, so that you can either find one that is maybe similar to your field or bring innovation to your study by saying we're applying this model that was developed in other fields but actually might be applicable to our setting. And then the other, the next column, we identified studies that actually used the model. So we went looking not just for studies that had cited the model, but studies that actually applied it. And you can see for some, actually for many of the models that are listed, this is just a snapshot from the table, there were no studies that had yet applied that model. And so for a lot of models that are out there, there may be a complete lack of empirical evidence, or maybe we just couldn't find it, but we did look pretty hard to find at least one example for every study. But that can be really helpful if you're looking to use one of these, to be able to go and see how it's been used before. So I just wanted to give a zoom in of that table. This is all in the appendix table that should be downloadable from the journal website. But again, we added these extra pieces of information in the appendix that aren't in the regular version of the paper. So the next thing we did was worked with a couple of other authors who had done reviews of models and frameworks, particularly the ones that we had been missing or we had excluded, like the 26 models that were focused on D&I practice as opposed to D&I research. And we combined with a couple of these other authors to develop a website that included the 61 models that we have, 25 models from another study, and then 33 models from another study. And put them in this searchable website that has available that you can search for whether your model is focused on dissemination or implementation, what level of the social ecological framework your study is going to be at, or what I find to be really useful is if there are specific constructs that you are really looking to be part of your study, that you can make sure that the model has those constructs available. And so this website is just online, it's free to use, and you would just go to the website and click select, and it will let you search for models based on these criteria. We also developed more recently some guidance for how to select an appropriate model, since there are many to choose from. One of the most important, and this is probably true for all the decisions you're making in your research study, is what's the research question that you're trying to answer. And so looking in the literature to try to find what's available around your question, articulating aims, and deciding what evidence your study is trying to provide can be a first step in picking a model that's geared towards providing the evidence that you are looking for. Looking at how you want to use your model. So there's been another review article that, and actually the link is at the bottom here to that article, propose different categories that you might be using the model for. So for example, a process model describes how the process of research translation is happening, whereas a determinant framework helps you understand some of those implementation outcomes, so acceptability, feasibility, what might be affecting that. So is it barriers, is it facilitators? It helps you think about what the context is for where your intervention might be happening. And if that is a purpose of your study, it can be really helpful to use a determinant framework to make sure that you're identifying what all the important determinants of the implementation outcomes might be. Another category are models that seek to explain or understand the implementation effort. So if the intervention worked, why? Or if it didn't work, why not? And these are drawn from a couple of different backgrounds, sort of classical theories, or other theories that have been designed for implementation research. And finally, there are evaluation frameworks. So one that we, I think, as in nutrition and physical activity are familiar with, like REAIM, that spends a lot of, the model is around evaluating the implementation effort. So what was the reach? What was the success of implementation? And so we find, especially with this category, if you have especially a larger type of study, it may be necessary to pick multiple models to achieve these different purposes. So you may need a evaluation framework as well as a process model. So one to sort of tell you how the translation will happen, and another to evaluate that effort. And this is just another figure of how those models look, but in the sort of middle are the ones that sort of help you understand what happened in your implementation effort. The process models on the left guiding what happened in the implementation effort, and then an evaluation model to help guide the evaluation of that effort. Again, social ecological level can be a helpful distinguisher in making sure you have a model that fits your study. We separated out models based on whether they hit at the individual, organizational, community, or system. Policy is also something that we often in nutrition and physical activity are seeking to understand, and that could be big P policies like government regulations, or it could be small p policies like what happens within an individual school. So again, this is our website. It is searchable and free to use online. Just a review of some of the questions. I know I went into some details, but there are other things that you might consider. Models have varying levels of measures available to assess the different constructs. Some models are really robust in terms of their measures that have been developed. Others don't have any measures associated with them yet, so that might guide which one you want to choose. And again, a place where this sort of leaves us is how you might adapt a model to be used for your study. So there's all of these different models that exist. You may narrow down to pick one or a few that are going to be applicable to your study. But even then, they may still need to be adapted, which can be sort of another step to make sure that the model fits your study. So I think I'm going to turn it over to Steph to talk about designs and the type of study where you might use these different models.
Great. Thank you, Rachel. I'm just going to flip this over here. So I'm going to build on a lot of what Rachel has already been talking about. And I think there's a lot of overlap in how the choice of study design happens within D&I research as within other phases of research like efficacy and effectiveness. So I think however we can kind of just highlight those similarities rather than and point out the nuances within D&I research, that's helpful to kind of translate your own deep knowledge, and much deeper than mine, in all honesty, knowledge of study designs and how you can use it within D&I research. So I've kind of boiled down the considerations for study design into three broad categories, thinking about, again, what is your research question? Like Rachel mentioned, it's kind of the central part of the research enterprise. Then also thinking about what type of evidence you need and what level your implementation strategies and evidence-based interventions operate. So if we think back to this diagram of the efficacy to implementation research spectrum, you see in this dissemination and implementation studies box that there are, in fact, several different types of dissemination and implementation research. So these are 4 phases that have been identified as the phases of D&I research. So these range from exploration to adoption, implementation, and sustainment, going from kind of the initial identification of implementation strategies that are appropriate to how and what is needed to sustain the implementation of an evidence-based intervention. And within each of these 4 phases, there are different research questions that can be asked. So it's not just we're doing a D&I study and what's my research question, it's what's the particular angle or particular part of D&I that I'm thinking about. So when you're thinking about identifying implementation strategies that are appropriate for your setting, maybe some sort of qualitative work or an observational study might be more appropriate. And then when you're thinking about testing the impact of an implementation strategy or a bundle of implementation strategies on an implementation outcomes, that's going to lend itself more to an experimental design, perhaps a randomized design as well. And so also thinking about what your comparison is, again, this is kind of just basic research, but I think it really holds true here in D&I as well. Whether you're thinking about your comparison by group and by time, and making sure that those that this is really explicit within your work. Also thinking about the type of evidence you need. So whether it's quantitative or qualitative or some combination of the two. And there is really good work by Larry Palinkas. I have the reference at the end of our presentation if you want to read more about the integration of quantitative and qualitative methods within D&I work and how one can inform the other or vice versa. But I think the how and why and the context of D&I is so important that some sort of combination of both quantitative and qualitative measures are important so that we can understand what sort of adaptations need to be made as we translate evidence-based interventions. And a lot of the evidence that, or the type of evidence that you need is largely dependent on who your stakeholders are. And engaging them early and often in the research process is so important for D&I work. So making sure that the public health practitioners, that your clinical practitioners, that the larger level government, healthcare systems, and individual patients or individual population members, making sure that the type of evidence that we're giving them is relevant to what they need and can help them implement what we learn as researchers into practice. And the last piece is to think about what strategy or what levels our D&I strategies and our interventions are working at. And I think this is particularly, this is generally pretty easy for us as behavioral researchers to wrap our heads around because we're doing these things and we're thinking about these sorts of things already. So we have kind of 4 different levels at which change can happen. So are we making changes within or to an individual, within a group or a team? So maybe that's a group of doctors within a hospital or a group of school administrators, and then kind of thinking about the organization as well. So the school, the community health center, hospital environment, and then that's all of course, nested within the larger system or environment. And we can have dissemination and implementation strategies and components of our interventions that work at any and all of those levels. And D&I is kind of inherently multi-level because you're implementing something within some sort of organization or within a setting or a community to then in turn impact individual behaviors. So we want to make sure that we're capturing changes at each of those levels. And to highlight this, we recently published a review of the research designs that are used in D&I protocol papers. And we've categorized them according to the consistency of different design components. So where they were assigning their treatment arms, what levels the D&I strategies were acting at, and what levels they were measuring. So if you were randomizing schools to an intervention, intervening on teachers, and measuring children's outcomes, you don't have the consistency. You're not measuring implementation outcomes at the school level or what's happening with the teachers. And we want to make sure that we are keeping all of these things consistent. So thinking about the range of study designs that are available to us, Some other folks, so Brown and colleagues conducted a review of designs that are available to dissemination and implementation researchers, and they proposed research within each research designs as falling in one of the first three categories, so either within site, between site, or within and between site. And then we have this fourth category of hybrid designs, which I'll get into in a little bit, but essentially they combine effectiveness and dissemination and implementation research. So we'll go through an example of each of these. So things like interrupted time series are particularly helpful when you don't have control over an evidence-based intervention when and how it's being disseminated or implemented. So if we think about something like a school healthy lunch standard, so we would have evidence that that would have positive impacts on children's eating habits, and perhaps we were able to influence a dissemination strategy of making this having schools adhere to this policy. So there was a policy mandate, and we were looking at the implementation outcome of the adoption or compliance with this policy. And so we would, as you see in the graph on the right, measure compliance at multiple time points and overlay that with when the policy mandate was enacted, so we can look at what happened before and after the policy went into effect. And so what we're able to do here is evaluate natural experiments and things that are already happening within D&I research and kind of understand how and why things are changing. Most of you will already be familiar with factorial designs, but here we're looking at the combination of at least two implementation strategies and multiple levels of each of those implementation strategies. And it allows us to understand the effect of an implementation strategy by itself or in combination with others. So if we were thinking about something like implementing a walking program that was implemented within senior community centers that had already shown to be efficacious, we would maybe think about how we would make that fit within senior community centers. So looking at maybe the impact of tailoring implementation efforts and ongoing consultation, and if either or both of those are necessary for successful implementation, thinking about success there as the appropriateness of or the fidelity to that walking program. And then of course we can have fractional factorial designs where perhaps one or more of those different treatment boxes are excluded. The SMART design, so the sequential multiple assignment randomized implementation design, or SMART trials, is a special case of the factorial experiment. And what we have here is pre-specified points at which we modify treatment. So we would perhaps have an initial randomization into two different treatment arms, and then depending on how organizations or participants reacted to those initial treatments, we would be able to modify or change what the non-responders were exposed to facilitate more successful implementation. And so this allows us to not have to wait until the end of a very long and expensive study to understand that if we had been able to modify our implementation efforts at month 2, that we might have been able to have successful implementation. So here, if we think about something like a physical activity curriculum in early care and education centers, perhaps we would want to test these different, a couple different implementation strategies such as audit and feedback or technical assistance. So we would randomize early care and education centers to either receive one or the other of those, and then let them attempt implementation of the physical activity curriculum for some period of time. And then at a pre-specified point, we would assess whether or not those centers were successfully implementing the curriculum, and then randomize those to either continue the implementation strategy that they received at the beginning or receive a different one. And then a newer design that is being used with more frequency is the stepped wedge. And so this is one type of rollout designs broadly, which are a type of designs that allow all sites or all clusters of a study to receive the dissemination and implementation strategy along with the evidence-based intervention at some point in time, but the time at which they receive that is allocated by the researcher. So normally what we see is a randomized step wedge design. So we have 3 different groups of perhaps say community health clinics that are randomized to receive a diabetes prevention or control program at some point. However, we have information on each group before, during, and after they implement. And so you're randomized to when you receive the intervention, not if you receive it. And this allows a really nice compromise so that stakeholders can, so that you're going to your stakeholders and saying, okay, well, it's not just that you're going to get one intervention or nothing. You're just going to, it's just going to be when you get it. That's the deciding factor. So it's particularly acceptable to our community partners. And then, as I mentioned, there's this kind of separate category of hybrid designs. And so what we're doing here is we're thinking about not just effectiveness research and implementation research as separate things, but perhaps there is something going on in the middle where we're moving slowly from one to the other. So other folks have come up with this, with these sorts of research designs, and they have identified, there have been 3 hybrids that have been identified. So type 1, type 2, and type 3. And type 1, in a hybrid type 1 study, what we would be doing is primarily assessing effectiveness of an intervention, but then also gathering some information on dissemination and implementation, knowing that if successful, we would want to go into a DNI study. Type 2 kind of balances the two, and then type 3 is really thinking about the effectiveness of dissemination and implementation efforts, and then kind of gathering any remaining effectiveness information that's kind of outstanding. So these are categories of designs that are not quite one or the other in terms of effectiveness or implementation, but are helpful for us who are kind of thinking, already thinking about implementation when we're designing an effectiveness trial. So in summary, I've highlighted a couple different factors that play into the choice of study design related to the research question, the type of evidence that you need, and the levels at which your DNI strategies and evidence-based intervention operate. And there really are a whole suite of designs that are available that can fit your particular nuances, your communities and settings, and your the particular logistics of your research. And I'd just like to take a minute and highlight some of the resources that are available to us. These are all freely available. These slides will be available so that you can get all of this information after today. The Dissemination and Implementation Research Core at Washington University has developed a series of toolkits, one of them relating to designs specifically, but they have some really nice guides to help people who are just starting out in the DNI field. The Penn State Methodology Center also has a lot of information on these different sorts of kind of innovative designs. And there are a series of webinars by the National Cancer Institute and one of our training institutes that are really great to kind of give some bigger picture framing to the DNI world. Additionally, we have a couple textbooks that we have come to know and love, including the most recent edition of the Dissemination and Implementation Research in Health textbook that was put out by Ross Bronson, Graham Kolditz, and Enola Proctor here at WashU. And here are the references I mentioned for my part of the presentation. And on behalf of Rachel and myself, I would like to thank the ISBNPA SIG and the technical support from Antonio and George. It has been a pleasure to present this, and we look forward to a nice discussion. Also, thank you to our colleagues here at WashU and to our funders. So Harriet, I'll turn it back over to you.
Great, thank you both. They were really great presentations. We've had one question submitted, and I've also got a question that I might start with Stephanie because it relates a little bit to what you've just been talking about, but Rachel, please jump in as well. Given that you both shared the diagram of the spectrum from efficacy up to implementation, and we've all sort of, in this field, we're quite familiar with that trajectory, and that implementation takes place in the real world and it's contextually relevant and driven. What's your views on where efficacy trials and that sort of designs that are around prioritizing efficacy actually fit in that spectrum? And, you know, should we be starting with efficacy or should we be starting with these hybrid trials to begin with?
That's a great question. I come from a training that was, you know, very rigorous and efficacy minded. So I kind of, I have, that's where I'm coming from. But I think as we get into a time in public health research that we have limited resources and we know a lot already. So maybe I think that it's wise to be thinking about effectiveness, and at least maybe if you really need a true efficacy study, to be thinking about what are the other pieces of information. So maybe it's not a hybrid type 1, but I think you should always be thinking about how your study would fit in the real world, because that's ultimately where it will go. So even if the primary purpose is an efficacy study and you're focusing in on that, I think that there are other things that you can add as secondary outcomes or other pieces of information that you can be gathering that will facilitate that research to practice pipeline.
Yeah, great. Rachel, did you have anything to add to that? Or?
Yeah, I was just thinking of one other. So the hybrid designs are really useful, but in one other concept that we've sort of talked about, and I think this is well discussed in the nutrition and physical activity literature, is the idea of designing for dissemination, so that even at the outset of your study, even if it's an effectiveness study, that you're thinking about that next stage, that maybe you're involving some stakeholders that would be helpful, or thinking about scalability sort of from the outset, even if the focus of your study is just to evaluate effectiveness or even efficacy.
Yeah, super. Okay, I'm going to turn to the webinar audience now. Femke van der Sal submitted a question regarding obtaining funding for D&I research, and what's your experience with having a focus on D&I and less on efficacy and effectiveness, potentially in the grants you've received? What would you suggest?
That's for you, Rachel.
So I do think, so I don't know about everywhere. Certainly in the United States, at our National Institutes of Health, we have a study section and funding mechanism, or call for applications specifically designated for dissemination research. So that can be a reasonable place to go for that kind of research, especially if you're doing a hybrid type design where you're getting some measure of effectiveness in a real world setting, and also then getting some D&I related measures as well. So I don't know if everywhere has that kind of mechanism. The other option is to be looking maybe outside of some of our traditional, maybe government funded institutes, but also to look at places that are practice-based, that then might have that interest and be motivated to fund and participate in even research that would apply directly to their practice.
Yeah, great, thank you.
And I don't know if you, Harriet, have any thoughts on that as our, with your international lens.
Yeah, I mean, in Australia, our major funding schemes, the National Health and Medical Research Council scheme, they're currently going through a big review, and we used to have fellowships that were actually designed for translating research into practice, and sort of some funding opportunities in that sense, but largely, whilst funding has increased in the last sort of few years. I think on average annually, it's about $20 million is for sort of dissemination type research, whereas over 200 million still goes to project grants, which are kind of generating new ideas. So it's more the kind of controlled trials. So slowly going that way. But again, I agree with you in that I think looking for sort of philanthropic money and other funding schemes is possibly more suited in some respects to this, but it's a constant challenge. But I guess hopefully in our field, because there is greater weight and interest coming to it, from my view, is that the dial is slightly starting to shift. So any new post PhDs coming up now will be in a much better position to try and get funding in the next few years than what, you know, sort of more mid-career researchers may have experienced. I will go back to the webinar question. So Leslie Cunningham-Sabo has asked, I'm particularly interested in D&I training related to community and school-based health promotion interventions. What training workshop or other training sources would you recommend? And this is from a USA-based researcher.
So we have in the US, the National Institute of Health has their TITRE training, which is not geared specifically towards, and I'm sorry, I'm not sure what the letters stand for, that's spelled TITRE. It's training in implementation, research, and health, something like that. And it's not specific to those settings, but they are pretty agnostic in terms of where your background is with the project that you bring. So there are likely to be some members of that faculty that would have the relevant expertise, but the training will be more geared towards the D&I component of that. I don't know of other, there is another one at NIH that's cancer focused. Again, that's not specific to schools or other community settings, but many of these are sort of try to be more tailored to you in that they'll help you with your project, but also then be more agnostic in their sort of D&I training components.
Okay. And just on the back of that, another question sort of similar from Sam Kassar is that, do we think that D&I researchers do enough, or should we have a role in upskilling stakeholders about different sort of theories and frameworks that might help them implement interventions, or is that something that's a researcher's responsibility?
So there is a robust, I think, area of research on understanding, and these are some of the models that we didn't include in our review, but others have, on models for specifically D&I practice. So how to improve on quality improvement efforts to actually put evidence-based interventions into practice in a practice setting in a way that's not focused on research. And so I don't know how much we as D&I researchers provide that to people or provide practitioners with that outside the scope of our own research studies. But there does seem to be a pretty robust development of models to inform those efforts.
Yeah.
And Rachel, where did those come from? Where did they land in terms of where are the groupings of those found?
So I put up some pictures of reviews. So the one by Sandy Mitchell, and I'm blanking on the exact name of it. They're all included in our searchable website. The reference is on that slide. It was in the journal Nursing Outlook in 2010. And so there could be an update from that, but that article by Sandy Mitchell reviews those frameworks.
Mm-hmm. Greek Cardinals has just said, very nice presentations, thank you both. And that funding is challenging, but also publishing. And do you have any recommendations regarding publishing in D&I?
Picking your journal, I think, can be helpful. Crafting your cover letter so that it's clear what, because sometimes D&I can seem esoteric because we use these words, but making it clear sort of how your study that may use these D&I terms actually informs the literature that's going to be applicable and accessible. And if you are targeting a broader audience, so for example, our review article was in American Journal of Preventive Medicine. It wasn't in like a D&I journal. Making sure to use terms and to put things into context so that it's accessible to a readership, so that a reviewer doesn't get it and say, well, I don't understand this. I think that can be helpful, but there are increasingly outlets for D&I research. So there's a journal, Implementation Science. There's some other journals that are more open to that kind of work, although a lot of those are kind of the pay journals. But that can be helpful too, because then they're open access, which can be really nice.
Yeah. And I'd just add to that that the Society for Implementation Research Collaboration are in the process of generating another additional journal for the field. So that will sort of widen that slightly. We've got questions flooding in now. So another one from Femke. What can we do in designing studies as well as interventions to promote dissemination and implementation after the trial? So is there something we can be doing in the design up front?
I am just pulling up, so there are a couple of good references. So Rachel mentioned this principle of designing for dissemination, and there are a couple of good references that I will add in. We'll figure out a way to get them to you all. But Rachel, do you want to give the scoop on that while I'm pulling this up?
Yeah, so I think again that, we call it designing for dissemination, but there's a couple of things I think that are components of that. So one is engaging stakeholders to make sure that you're getting the evidence that they need. So maybe it's they need cost, maybe it's they need number of hours, maybe it's they need how long the training will actually take their staff, whatever it is that your stakeholders really need, and engaging them way early. So before you get to the end of your study and now you have this intervention and you want people to do it. So I think that is critical. Partnership can also help that. And again, just if it's possible to get those measures and anything that can enhance the generalizability of your study without those, to the extent that it doesn't sacrifice too much your internal validity. I know that's Steph had our nice cartoon of a tension there, but something that's going to make it feel to a practitioner choosing an intervention, well, this could apply in my setting, as opposed to saying, oh, it only applies in a clinic that's this way or a school that's this way.
Yep. Do you have anything to add, Steph, or are you
Nope.
happy?
I think that covers it pretty well.
I think all our questions are done, and we've actually just approaching the end of the hour. So it's unless anybody wants to quickly submit one in the last minute or so, we're probably at a good point to start wrapping up. I'll just give it a second, but if anything pops up, I'll let you know. But I think, on behalf of our SIG, just want to say thank you to you both for your time and doing that. It was a really great webinar and really interesting. And as I said earlier, the link to this webinar will be posted on the ISBNPA website. So please share it with your colleagues who weren't able to actually log in today.
Thank you.
Okay. All right, perfect.
Thank you.